All right, welcome to Grand Rounds. We're going to get started. We have a special guest today. It's my honor to introduce Dr. James Barnes, originally from Farmington, Utah. Dr. Barnes completed his undergrad degree at BYU and then matriculated to VCU School of Medicine, where I first met him in 2018. Needless to say, it was very exciting when he eventually matched to VCU PM&R in 2022. Now well into his physiatry training, his professional interests remain deeply rooted in pediatric and neurologic rehabilitation, as well as musculoskeletal medicine. Today, he's going to share from his wealth of expertise on the complexities of multiple sclerosis. Outside of his impressive academic and professional pursuits, Dr. Barnes enjoys quality time with his family, engages in spirited fantasy football discussions, and diligently working on his vision board. He is truly both a gentleman and a scholar. Please join me in welcoming Dr. James Barnes.
Thanks, Trevor. I aspire to be a gentleman and a scholar in all I do. So today we're going to be talking about MS-specific considerations for the rehab team. Kind of a wordy title, but you'll see why I picked it later. As far as disclosures, I wish, but I have none. Learning objectives, briefly we'll kind of overview what MS is. Most of us have a pretty solid medical background, so we typically know. Kind of go over general rehab considerations, and then we'll get into the real meat of the talk of the MS specific considerations. MS at a glance is a chronic autoimmune inflammatory disease of the central nervous system. It's actually the most common cause of non-traumatic disability in young adults. Approximately 400,000 individuals in the U.S. are affected with MS, and it's extremely expensive. 28 million to the U.S. annually as far as cost to our medical system, and costs range up to around 54,000 per person. Based on personal experience with my family, the number tends to range between 70,000 to 100,000. So very expensive, very, it's a disease that impacts a lot of people in a lot more ways than one. As far as epidemiology of this disease goes, there's no clear etiology, and so we have found all sorts of crazy associations, largely probably in part to try and figure out why this is causing. And MS has a very kind of interesting and unique epidemiology. Females are 2 to 3 more times as likely to have MS compared to males. Males tend to have a more aggressive course, including more difficulty with recovery after flare, more rapid development of disability. The peak incidence of age of diagnosis between 20 to 40 years, so typically pretty young individuals, and around, so someone's not seeing slides. The lifetime incidence of MS is approximately 1 in 400 for non-Hispanic. All right. Okay, I think everyone can hear me and see my slides. So lots of migration studies have been performed with MS, and they found some really interesting stuff, such as a move from a high risk area, so more northern, farther away from the equator, to a low risk area around the equator. And during adolescence or early childhood, you adopt the risk of the new place you live in. Same has been observed from moving from the equator to a high risk area, but data is not as strong for that. And weirdly enough, it's associated with birth during specific times of the year. Higher association of development of MS with births in the spring, specifically March, April, and May, and lower association associated in the fall, with November being the specific one that was cited. Pathogenesis, we'll kind of briefly go over. So like I said, unknown etiology. We don't know what happens. There seems to maybe be some genetic component. A monozygotic twin though has like a 25 to 30% chance of developing MS is their twin who has MS. First degree relative about 2 to 4%, and then also the HLA gene, which I'm sure we know and love from many autoimmune conditions like such as lupus, type 1 diabetes, celiac disease, Crohn's. If you're a heterozygous carrier, you're 3 times as likely to develop an MS. If you're homozygous for that gene, you're 6 times as likely. Symptomatic Epstein-Barr virus, so infectious mononucleosis. There's a pretty strong association with that. And typically, pretty much everyone is exposed. It's like 50% by age 5, 80, 90% by young adults. And if you become symptomatic with mono, there's an increase of MS by 2.3 times compared to those who were exposed and did not become symptomatic. Cigarette smoking, also higher rate. Cigarette smoking is bad for you. We all know that. It's associated with so many things. Increased BMI among females between the ages of 10 to 20 years old for some reason seems to have some association with MS development later on in life, and some evidence for increased sodium intake. But like I said, unknown etiology, and so we have all sorts of weird and funky associations with MS. Presentation of MS, so it's an inflammatory autoimmune disease, typically demyelination of the central nervous system nerves. It's extremely variable, can be anywhere along the central nervous system. So some patients may present like a spinal cord injury, some patients may present like a stroke. It really just depends on where the symptoms are at. Common presenting symptoms, the most common one is optic neuritis, which is blurry vision and pain. Numbness, paresthesias can also be common, weakness, motor dysfunction, and fatigue as well, which can be, a presenting symptom of MS. It's a diagnosis of exclusion. Obviously, if someone comes in with these symptoms, you have a pretty wide differential. Things like neuromyelitis optica, B12 deficiency, vasculitis, transverse myelitis, just oncologic, hematologic, metabolic things can also kind of present similarly. So it's important to rule those out before you say definitively, yeah, this is MS. As far as the diagnosis of MS goes, so the classic phrasing is disseminated in time and space, which basically means that MS attacks or flares have to involve 2 different areas of the nervous system at 2 separate times, at least a month apart. So for example, someone comes in with optic neuritis, and then that gets better. A month later, they come in with some weakness. That would be kind of the time and space, just because they're 2 different areas of the CNS. It's typically a clinical diagnosis, but some other things can be helpful to make the diagnosis, such as MRI. You can see the 2 MRIs, the cervical MRI. There's some kind of attenuated areas kind of around C4-5 in the spinal cord, and then the brain. A really common place to get MS lesions is periventricular. There are other places you can get it as well, but this is a pretty classic finding. These are known as Dawson's fingers. If MRI is not really conclusive, or if it's negative, doesn't necessarily rule out MS. So you can get some CSF studies. You do a lumbar puncture, and with that, you'll see oligoclonal bands. This is done less commonly nowadays, but it is still done if MRI, CSF, clinical symptoms are not totally giving us the diagnosis. You can do something called evoked potential testing. Basically, how it works. So this is an example of visual evoked potential testing. So they attach electrodes as you can see, kind of around the visual cortex of this patient. And they have this screen, and this little red dot will flash and alternate at specific areas. And then you can kind of see on the left side of the screen, there's, it reading their brainwaves, for lack of a better term. And it can determine if there is slowing of the sensory nerve. So they have data on what the average, um, like between seeing the red dot and then seeing something pop up on the monitoring screen. They have data on what the average is, and if there's slowing in that response, that can maybe be a sign of demyelination, which would cause slowing in the transmission of the nerve signal. This is the specific criteria to diagnose MS. It's the McDonald criteria. Not as important for us to know, but definitely helpful. And it's basically just to illustrate there's a lot of different ways you can diagnose MS, but it's primarily a clinical diagnosis with imaging can be helpful. Subtypes of MS. So the most common subtype is relapsing remitting MS, where is kind of the common one you think of, where there's exacerbation or flares followed by periods of remission. That's about 50 to 65% of individuals. Eventually, some of the relapsing remitting folks can transition to something called secondary progressive MS, where it's kind of it's signified by like a lack of exacerbations, lack of remissions. Oftentimes, MRIs will look the same as well. Like there won't be any new lesions, but they kind of persistently just worsen over time. A lot of the times, the disease modifying treatments we'll talk about don't really do much at this point, and it's all about just preserving function for as long as possible. There's no real biomarker that can kind of give us any idea of who's at risk for developing secondary progressive MS, or who will, or like when we can do it. There's no specific time period. Progression and accumulation of, decreased function and disability is very variable between patients. A little more rare is primary progressive MS. That's about 10 to 15% of individuals. It's like secondary progressive, where there's no flares or remission, kind of persistent worsening over time. And the most rare, but the most severe, is progressive relapsing MS, where it's basically the exacerbation and flares of relapsing and remitting, but there's no remission. So you kind of gradually worsen with some acute worsening of your symptoms. Treatments, mainstay of treatment nowadays are the disease-modifying therapies. IV infusions are the big one. They're to modulate the immune response. They're typically monoclonal antibodies. They're designed to kind of, turn off or turn down the immune system to prevent flares and progression of the disease. It's really common to develop immunogenicity and the treatment not be as effective. And so you may need to switch treatments to a different one that, the patient hasn't developed antibodies to. Lifestyle changes, obviously extremely important. Having good diet, exercise program. There's definitely a big role for integrative medicine in the treatment of MS. For acute flares, sometimes a short course of IV or oral steroids will be given for an acute flare to try and calm everything down real fast. And then a newer treatment, I mean, it's been around for a bit, but it's kind of just now starting to gain more evidence, is the stem cell transplant and bone marrow transplant, basically for patients with MS. This on the top right, you can kind of see the 2019 study. It was kind of the first one. It was in the JAMA journal. It was a randomized controlled trial of 110 patients from 2005 to 2016 that had relapsing remitting MS. They were randomized to either get disease modifying treatment of, the highest efficacy they could get, or a stem cell transplant, and they found that the stem cell group had a prolonged time to decrease progression compared to the disease modifying treatment group. In 2023 is kind of an observational study of way more patients. This one had 4,915 individuals, and it was found that the stem cell transplant was superior to fingolimod, which was like one of the very first like oral medications. So it's not as used anymore. So take that for what you will. It was kind of compared to an old one, and it was marginally superior to natalizumab, which is one of the disease modifying treatments. So definitely an interesting area of study. Can we reset the immune system basically to try and treat autoimmune conditions is pretty interesting, but still a lot more research and data is required for that probably. For general rehab considerations, we won't go over too much of this just because, as rehab doctors, we're very used to managing a lot of these things. Neurogenic bowel bladder, pain, ambulation, mobility, transfer, spasticity, cognition, speech, and swallow all can be affected in patients with MS. We're all, very, very used to managing this type of things. The important thing to remember is that MS will give you, it's a central nervous system disease, so it'll give you upper motor neuron signs. So that's just kind of something to consider as you're treating these patients. Okay. As far as MS specific considerations, we'll kind of go through each one. Just to start off, there are some screening questionnaires where you can basically assess disability related to MS. This one, the Expanded Disability Status Scale, is the most widely used one for clinical and research purposes. It's a questionnaire where basically you go through these things called the functional systems. And I'll show you a picture on the next slide of what those are, and you just grade them to basically see how debilitated they are. And they kind of go from 0 being normal neurologic exam to 10 being death due to MS. So it ramps up pretty quickly there. But around important places to know around 6 is kind of where like the ambulation impairments kind of come into. We're needing like needing equipment, that kind of thing. This is developed by Dr. John F. Kurtzky. He was a neurologist and neuroepidemiologist. He worked at the VA, and he also worked at Georgetown for a long time. Very much a pioneer in this field. These are the functional systems scores. Yeah, so they are sensory, bowel bladder, visual, just different aspects of an individual's system. I mean, of their symptoms that may contribute to their function in one way or another. One really interesting thing with MS is physical activity. It's kind of like a catch-22. MS patients were previously advised by many physicians to not exercise due to overheating and for fear of worsening disease course. Some of these patients, they'll describe, if they go too hard, that they'll pay for it for days, basically is what they say. But there's been multiple studies showing the benefits of exercise in patients with MS, such as improving balance, walking ability, endurance, fatigue, quality of life. Resistance and aerobic exercises were most effective for improving specifically fatigue and quality of life in people with MS. And younger age kind of showed greater improvements. And the important thing is to start these exercise habits early. So that's one thing that's not as commonly emphasized to patients when they're first diagnosed with MS, but is to start early, and you can potentially delay and slow down your progression of the disease. It's very important for these patients. The one thing though is there's no great data on exercise tolerance, so kind of talked about it as the catch-22, where you can't go too hard or else you'll get too fatigued, but you need to go enough to get those benefits. The typical recommendations kind of follow the Canadian Physical Activity Guidelines. This is what the MS Society cites as their recommendations. It kind of is, in a nutshell, is 30 minutes twice weekly of aerobic exercise and resistance exercise twice weekly as well. They can be done at the same, like on the same day, or they can be done on different days. Doesn't really matter. These are moderate intensity, so definitely not too light, but you want to not go too hard, and a gradual increase. So starting slower and kind of working your tolerance up. There is some research suggesting higher intensity exercise may be appropriate. These are kind of some smaller studies, but I think definitely worth noting where one has
the general Sawtooth Wilderness area. Now, for those that don't know, the Sawtooth Wilderness
so the high intensity aerobic exercise, one is high intensity interval training and one was just high intensity aerobic exercise, showed that a lot of these patients could tolerate that and they had benefit to their symptoms. They used a lot of exclusion criteria in these studies. Typically, a lot of the patients were pretty young and newly diagnosed, and
was a little
otherwise based on
frustrated
pretty helpful.
yesterday because I was like, already
Um, As far as the Canadian physical activity guidelines that I referenced a little earlier, these are them. We won't go in depth into them, but just wanted to show you. They're in a pretty purple. Fatigue is one of the most common and disabling symptoms of MS. Patients will describe it as a brain fog, reduced motivation. It's important to note that there's a difference. Patients with MS often get two types of fatigue. There's a peripheral and a central fatigue. A peripheral fatigue is the fatigue we typically think of. Fatigue after exertion is relieved by rest, but the central fatigue is much harder to treat. It's kind of a constant baseline exhaustion. Sometimes difficulty with arousal and attention can lead to worse vision and function, and it's typically not relieved by rest or very minimally relieved. This is obviously very difficult to manage because often patients feel much more tired than they look. There's a significant impact on their function, quality of life, relationships with other people, ability to maintain their occupation. Just because people who are not expecting to deal with central fatigue in MS oftentimes, don't necessarily give it its due credit, as far as, giving people grace when they're dealing with these types of things. There are two different types of fatigue that we also talk about with the central fatigue. One is primary fatigue attributable to the MS itself, and then secondary attributed to other causes. Obviously, thermal regulation, mood, anxiety, sleep disturbance, endocrine, hematologic, all those things can affect your fatigue. One important thing I will note for the sleep and rest, insomnia is very common in patients with MS. It's about 10% in the general public, but 40 to 50% of patients with MS. Lots of things could be exacerbating this: poor sleep, hygiene, pain, spasms, nocturia. So just something to keep in mind when you're treating patients with fatigue with MS. Treatments. So treating the underlying causes, kind of like we talked about, sleep hygiene, any disorders, pain, spasticity. Making sure they maintain appropriate physical activity, not too much, but not too little. Making sure they're aware of their triggers, such as heat, overexertion. I listed heat again just because it's that important. It's a really common complaint. Patients can have energy conservation training. Sometimes this is done with therapists, but you have to find very specialized therapists to kind of teach you how to do that. The MS Society has some good videos to teach patients about this. Caregiver family training is super important just because fatigue can happen suddenly. And so caregivers and family need to know that, hey, this happens and, it may not be the patient's fault. It may be the cause of their disease, and to be patient with them and be willing to help out when necessary. Medications as well. It's mostly stimulants with things like amantadine, methylphenidate, modafinil, atomoxetine, etc. For gait is the most common disability in MS. 75% of patients have problems with their gait. We're obviously well aware of the risks of gait impairments: falls, weakness, spasticity, decreased bone density, fractures, list goes on and on. The most common way to assess a patient's gait, besides, just looking at them, is you can do the timed 25-foot walk test, otherwise known as the T25. You basically just time them walking 25 feet. If it's 5 seconds or less, it would be normal. And if there's a 20% change in walking speed, that is would be a clinically important change and something we'd possibly like to treat with more equipment. It's the most feasible test just because it's easy to do just in clinic, or it's easy to do with therapies. The 2 or 6 minute walk test is typically only done with physical therapy. It's obviously a lot longer, more energy is needed, but it gives you a lot of data like speed, fatigability, heart rate. You can monitor them the whole time. And to treat gait, obviously therapy is our go-to for any type of treatment with the movement is medicine. Mobility aids, walkers, canes, wheelchairs if needed. Peripheral nerve stimulating. So this is an example of a bioness kind of around a patient's leg where there's a sensor underneath their foot, and it can feel when they take pressure off their foot, and then the device will shock their dorsiflexors to kind of pull their foot out of the way so they don't drag their toe. And then bracing obviously is important as well. Kind of going on with gait, just to mention a few other things pretty specific to MS. So there's a medication called dalfamipridine or Impera. It's a potassium channel agonist, and so if we remember our little diagram in our head of the action potential, it will potentiate the duration of action potential or make it longer. That can enhance nerve conduction, lowers the seizure threshold, so it's contraindicated in patients with a seizure disorder. Other possible side effects have been UTIs, vertigo, headache, falls, and insomnia, and it is renally excreted, so it's important to monitor patients who are started on this medication. But it is interesting because it is one of the only medications shown to maybe have some benefit in improving gait in patients with MS, and specifically gait speed. The data, like the two phase 2, like phase 3 randomized controlled studies that are there are pretty small, but it was enough for the FDA to kind of give it emergency use authorization. So in the trial, a third of patients improved by 25% for their T25 test, and about 30-40% of patients respond. We don't know why. We don't know why some people respond, some people don't, but it's a common thing just to try to see if it will help. The PONS device, so this stands for Portable Neuromodulation Stimulator. I don't totally know why it works. A lot of people don't totally know why, but essentially what you do is you have the patient bite down on the stimulator that stimulates the tongue, and through some pathway, it'll send impulses through the sensory nerves in the tongue to the brain, and those signals are transmitted to the motor area of the cortex, and then down obviously to the muscles used for walking. It's an FDA approved treatment of gait disorders, specifically in patients with MS. Very small studies again, but it was helpful in those studies. Typically, therapy with this lasts 14 weeks. First, the patient starts it in PT and then can transition to doing it at home. Each session is about 20 minutes. And these devices are super expensive. They're like $14,000 to $25,000, but has shown some benefit. Let's see if this will pull up for us. So this is just a quick video of someone on the left. It was his first week using the PONS device, and on the right, after 14 weeks of using it. Obviously, you can see there's still some abnormalities on the patient the same guy, but in the right, you can see some abnormalities, but definitely gait speed is a lot quicker. His balance seems a little bit better as well. So it's an interesting and kind of novel technique to try and treat these gait disorders in patients with MS. Mood disorders. So depression is very common in patients with MS. At least 50% of patients with MS have it. There is an overlap of symptoms between fatigue and depression, so this number is probably a little underdiagnosed, to be honest. Lifetime prevalence is 3 times that of the general population. There's many theories as to why. So flares themselves may predispose you to having depression, and vice versa. Having depression may predispose you to having a flare. Typically, patients with MS are in young and otherwise healthy individuals, and they look a lot better than they may feel. It's kind of like a lot of our Asia D patients that we see, where they're functional enough to be frustrated about what they can't do, essentially, is what it is. Really, it kind of takes a village to help treat this. So there's medications, the typical ones we think of, the SSRIs and stuff. Psychological counseling is very important. Um, Getting patients with a rehab psychologist. There is a few, not super important for uh, our talk here today, but it's important to know that there are some screening questionnaires as well, specifically designed for MS and picking up mood disorders. Um, Another interesting thing about MS is this thermal regulation. We've kind of referenced it several times already, but the idea of it is that the demyelinated nerve is more vulnerable to heat-related changes because the sodium channels are altered, and which would lead to decreased action potential amplitude. So, patients without myelin already having a hard time sending nerve impulses, and then if we apply heat to these and decrease it even further, it can exacerbate symptoms. There's some thought that autonomic dysfunction also contributes as well. It's known as the Utah phenomenon, where there's a transient worsen of MS symptoms with heat, specifically, but also exhaustion, infection, dehydration. Um, Weirdly enough, prior to MRI, one of the adjuvants we used to diagnose MS was called the hot bath test, which sounds terrible, but basically patients were immersed in warm water around 35 to 40 degrees Celsius and observed for worsening of their function or symptoms. And that was kind of viewed as a positive test of, hey, this is probably MS. Obviously, it's discontinued after the advent of the MRI. And unfortunately, some patients had irreversible changes from this test. So it definitely wasn't um, without its risks. The most important way to treat thermal regulation is preventing it. So, of teaching patients of what may trigger their overheating, avoiding warm baths and hot tubs. The recommendation is no greater than 84 degrees Fahrenheit, which is pretty cold if you think about it. If you think about what mini showers, baths, and hot tubs are all set to. Um, Pre-cooling, especially before exercise or any strenuous activity, with ice water or a cool water bath. The study up at the top right kind of was a good study where basically showed that some cold water ingestion was improved exercise tolerance, specifically the ability to last longer in exercise in patients with MS. Head cooling is important, and then there's cooling garments. They can be either active cooling. So on the bottom right, those are two examples of some garments. She's got a vest there that she can fill a bunch of pockets with ice packs, and then the other woman on the to the side of her, has a scarf that can be cooled and a waist belt that can be cooled as well. You can also get wicking garments that can help with heat. I've seen people get creative and just take t-shirts and sew a bunch of pockets to it and then just fill those with ice packs, whatever works. Um, Spasticity, so this is one we're very used to treating as PM&R doctors, but there's a few specific MS considerations I think we should note. Specifically, 85% of patients with MS have spasticity, so essentially all. Um, Much more common in the lower extremities for whatever reason compared to the upper extremities. Don't totally know why. It's important to assess them dynamically with gait, just because you may be in the office and maybe your modified Ashworth scale isn't too bad, but when you watch them walk, their knee extensor tone or something, or their plantar flexion tone can really limit their ability to walk and have a functional gait. Um, Stretching, bracing, orals, Botox, we all know how to treat spasticity. One important note with the baclofen pump, patients with MS, for whatever reason, are often much more sensitive to intrathecal baclofen and often require much lower doses compared to spinal cord injury. So that's important, whenever you're doing a intrathecal baclofen trial, or whenever you're, increasing a patient with MS's dose to kind of the low and slow approach is often safer. Let's see this one. Oh, this feels like an important one to pass before. Okay, we got 5 minutes before we celebrate, well, before we remember September 11th. So there's some evidence as well that medical cannabis may be helpful. Obviously, like with all research done in medical cannabis, the results are a little bit mixed, but in this specific study down in the bottom left, patients experienced pretty significant improvement after initiation of medical cannabis. 72% reported improvement of their pain, 48% reported improvement of their spasticity, 40% improvement of their sleep. In the same study, there was a significant reduction in opioid use if they were using it at the time, and also a decrease in muscle relaxant use and benzodiazepine use. The most common adverse reaction to the cannabis was fatigue. That was reported in 11% of patients. So definitely another area of research that could be involved, specifically with patients with MS. Kind of some miscellaneous stuff just to kind of bring us home. So neuropathic pain can be common in MS, and it's important to screen for that. There are two specific signs that are found in MS: the Larimet sign, which is kind of the electric shock down the spine, worsened with neck flexion, and then something that's colloquially called the MS hug, where patients will report kind of significant tightness around their ribs as if they're being hugged very tightly, and that would be an indication of they may need some treatment for neuropathic pain. Cognitive impairment is common in MS as well. If you think about, anywhere in the CNS can be affected, so cognition centers as well. 40-70% of patients with some level of cognitive impairment. It can occur at any point in the disease timeline. It depends on where the lesion is located. Then obviously we know about the cognitive rehab, psych, speech therapy. It does seem with the cognitive impairment, specifically with MS, that an increased cognitive reserve. So, like a patient's increased intelligence or increased cognition prior to developing cognitive effects from MS seems to be protective. And so it's recommended often in patients with MS to do cognitive leisure activities like reading, puzzles, art, writing, that kind of thing. Pseudobulbar affect can also be seen in patients with MS. This is the laughing and crying at inappropriate times. It may be socially isolating, obviously due to inability to control emotions. Kind of bring it home, us as physiatrists, we can make a really, really big impact. It's a very underserved population for PM&R, and due to rapid advances of disease-modifying treatments, a lot of times MS specialists don't have time to necessarily treat these conditions, and may not have the expertise as well. Huge long list of things we can do. It's something I'm very passionate about. My dad has had MS for 28 years now, and had never heard of what a physiatrist was until I went into the field. So it's definitely a very underserved population. I guess the recommendation I would make as part of this talk is to offer your expertise. These things that are very day-to-day typical things for us, bowel, bladder, spasticity, are often not so for a lot of other physicians. And so we can make a big impact specifically in this population. These patients really benefit from, kind of the overview of the functional rehab outlook. These are my references, and thank you so much. Hopefully made it in time for 9/11. More than happy to answer any questions, but if there's none, that's okay too.
Hey, James, this is Dave Seafield. I just want to thank you for highlighting, as you said, a really important area of neuro rehab that we can be very impactful for. It's a little like Parkinson's or maybe ALS, areas where we may not feel as comfortable doing things, but it's really just standard PM&R approaches in partnership with our neurology and other colleagues. So thanks for really highlighting that and really bringing it to the fore. Much appreciated. Great work.
Yeah, thank you.